tonight if they can. And a reminder that this event is primarily about public hospital funding and the impact that has on patients and doctors, and also modernising Medicare and how this must be addressed in order to save general practices in communities. It's a high-level discussion, can't possibly get into the nitty-gritty in 90 minutes, and we appreciate that people might have questions and concerns about a range of topics tonight, but if we could try and keep it to the core issues, that'd be fantastic. We have a number of guest speakers with us here tonight, so in the interest of ensuring we keep to time, we've got a timer that will appear on the screen. And we've also got people joining us from right across the state. It would be great if you could let us know where you're from in the chat so that we know who we're talking to. Jacinta's just saying bad connection here in Queensland with the rain. Yeah, really conscious of a soaked Queensland tonight. So if you're coming in from somewhere really wet, thank you so much. Let me just quickly run you through how things will play out. First, we're going to discuss the issue of public hospital funding, which is an issue that the AMA is campaigning heavily on throughout the country. Then you'll hear from a patient who has experienced public hospital emergency departments, is on a long elective surgery waitlist, and relies on seeing a GP to manage her health in the meantime. After that, we'll look at the issue of Medicare and the urgent need to save general practice. And then finally, we'll hear from some candidates and political representatives about their plans for the future of both issues, public hospital funding and Medicare. Tonight we have a range of politicians joining us, Dr. Angela Egan, the independent candidate for Herbert, who's also an AMA Queensland member, Dr. Kamala Emanuel, Socialist Alliance Senate candidate. Senator Nita Green is here from the Australian Labor Party, and Penny Allman-Payne, Queensland Greens lead Senate candidate. Important to note that both the Liberal, National and One Nation parties were also invited to this evening's event, but were unable to provide a representative. Of course, there are a myriad of things we could focus on when it comes to health in this state, but public hospital funding and Medicare are going to be the key focuses tonight. So I'll be encouraging everyone, including our political representatives, to try to stay on topic. As I mentioned earlier, we want this to be as engaging a discussion as possible. So use the chat, post your questions, your comments, and we'll try and relay them back and forth to speakers. We'll have a Q&A session at the end of the public hospital session, as well as the Medicare session. And then there'll be a chance to really delve into the politicians' views towards the end of the evening. So do remember to keep your questions coming through. So without further ado, let's get the virtual town hall underway. And first, I'd like to introduce Dr. Omar Khorshid, AMA President, who can set the scene at the national level and talk about the pressures on public hospitals throughout Australia. Dr. Khorshid.
Thank you very much, Rebecca, and thank you all for being here tonight. I'd like to add my respects as well to traditional owners, but also acknowledge that today, 202 years since the birth of Florence Nightingale, is International Nurses Day, and to recognise the extraordinary efforts of nurses around the world, their work in conjunction with doctors during the pandemic in particular, to support others and, of course, including putting their own lives at risk in many parts of the world. And, of course, this pandemic has propelled health to the centre stage of all of our lives and at the centre of government decision-making. But it's also shone a light on the deep cracks already present in our health system and the fact that those cracks are widening every day. Now, we do have a world-class health system, but there is simply no spare capacity. And especially as we come out of the lockdown phase of the pandemic, Australians are currently suffering and even dying as a result of that lack of capacity and lack of access. And you'd think, therefore, that when you've got a federal election coming, well, we've still got a pandemic going on, that health would really be at the centre of the discussions and thinking of those vying to be our nation's next leaders. But unfortunately, that has simply not been the case, despite repeated polling saying that voters are actually really interested in health. That's why the AMA is campaigning to end the hospital logjam and to support our primary care system, our general practitioners, by modernising Medicare. Our campaign has demonstrated that hospitals right around the country are in logjam and they're getting worse. Our logjam finder allows voters to look up their own local hospital, generate a report card or a message and send it to their local MP. That's hospitallogjam.com.au. Our public hospital report card, issued every year, but so important this year, shows how each state's performance has been declining over time. And our ramping report card, released just today, shines a light on the fact that many Australians cannot count on an ambulance coming on time to help them in an emergency. Now, of course, ambulance ramping is caused by overcrowded EDs, not the ambulances. EDs are overcrowded because they can't get their sick patients out onto the hospital wards. And hospital wards are full due to a lack of investment in capacity by both levels of government, not enough beds, but also because they can't get these patients out of the wards into aged care, into the disability system. So the whole system is jammed up. That's why we've called it a logjam. And it's made worse by the fact that GPs are struggling to see patients within a reasonable time now. And for the first time, we are actually seeing some GP patients presenting in higher numbers to EDs. And our whole model of primary care, of course, was designed in the 1980s. Now, multiple hospitals in Queensland make our list of the most log-jammed in the country. Redcliffe, Cairns, Townsville, Sunshine Coast. Some of those are in marginal seats, but all of them need help. And lives have been, are being, and will be lost in the future due to under-resourcing of our public hospitals. That's why we'll keep campaigning every day of this election for a new funding agreement, one that ends the blame game between the Commonwealth and the states and provides additional funding by moving to 50-50 between the Commonwealth and the states, and importantly, scrapping the cap on Commonwealth investment. This is a position backed by all state and territory governments, and in particularly by the Queensland government. But of course, neither party has committed to this plan, but both should. What is more important than health? And of course, something for everyone to remember is that any of us could need a public hospital, no matter how rich you are, no matter how good your access is normally. You never know when you're going to need your public hospital and whether, in fact, a bed will be available for you. So with 1 week to go in the election, we actually need your help. We need everyone's help. I would ask you to use your voice, be it on social media, talking to candidates, spreading the word in your workplace, using the resources on our website, putting up a poster in your practice where patients can see it. It all actually counts. It is helping us build some momentum behind this topic as we go into the election, only a week to go. And despite the polling, it will be close. So I'd like to ask you to have a little look at our Hospital Logjam website, hospitallogjam.com.au. Lend your voice to the campaign, however you can. And of course, for the GPs on the line, please consider doing the same for our primary care campaign. Critically important, modernisemedicare.com.au. That'll be covered a little later tonight. But really, I guess the synopsis is the next government will have no choice but to tackle these crises in our health system. We just, as the voters, need to know how they plan to do that. I'll leave it there. I will stick around for a while, but unfortunately I have another meeting, a similar event on tonight, so we'll have to disappear part of the way through this evening, but thank you for coming. Cheers.
Dr. Khorshid, thank you. And I'd love to get a sense of how our audience is feeling about the state of our public hospitals. You'll see in the chat there is a link, or you can enter the website and code on your screen or scan the QR code. Once you get there, please hit the heart to let us know that you're there. And a question will pop up on that screen soon, which asks you to list 3 words that best describe the current state of the public hospital system in Queensland. 3 words to describe the public hospital system in Queensland currently. So you might work in a public hospital, you might have been a patient, maybe you visited someone in hospital. It'd be great if you could describe it in 3 words. And it might take a moment to load, so just bear with it. But it would be really valuable if you could just take a moment to describe how you're feeling, and we'll be able to get a good sense of what is happening. A couple of words coming up immediately: poor patient focus, tired, underfunded, devaluing doctors, burnt out staff, distress, disaster, and dangerous. So a pretty challenging picture that you're painting so far. Keep those words coming through as a way of describing the public hospital system in Queensland right now. Fragmentation in the mix, overcrowded, cheap and dirty. someone says. Over-politicised, which is interesting in the context of federal election and with our politicians here tonight. Process-driven, again, I guess really important, depending on where you're coming at this from, to get your view of the public hospital system right now. Tragic, appalling, blocked and full. And devaluing doctors. I note that Eileen has put a note in the chat as well, just saying, hi everyone, I'm a GP in Cairns who's feeling a bit despondent, being constantly blamed for the lack of local GP services, despite working hard for nearly 20 years to help with the GP workforce. We'll come to GPs in a little more detail in the second part of tonight. But thank you everyone for your thoughts coming through. If you can continue to fill that in, it'll be valuable. Ineffective, poor patient focus in the mix as well tonight as well. Let's go to our next speaker, who is Dr. Bav Manoharan, Vice President of AMA Queensland, to give us his overview of the state. Bav, good evening.
Thanks, Rebecca. And wow, looking at those words, it really is depressing that there was nothing positive in that. And I think where Omar has given us an overview of the national situation, those words really reflect what Queensland doctors are feeling. There's been 2 years of COVID, and GPs and public hospital doctors at the front line and our other health colleagues have been really working hard to protect the community, but there's a sense of protecting the community whilst not being supported by the politicians and by the system. And I think whilst the public hospital report card that AMA puts out shows that Queensland hospitals are performing relatively well given the stretched resources, I think the ramping report card, the ambulance ramping report card that's just come out today, really paints a different and very dire picture. So 1 in 3 category 3 ED patients are not seen within the recommended 30 minutes. Elective surgery patients are waiting 14 days longer than those in other states for category 2 elective surgeries. The ramping report card shows that it's been 7 years since Queensland has met its targets of moving 90% of patients from an ambulance to ED within 30 minutes. In fact, 1 in 3 patients are ramped for longer than 30 minutes, which means 1 in 3 patients aren't getting the care that they actually need in an emergency department in the target time. Our ramping rate is actually the worst of the large states. We fall well behind New South Wales and Victoria on this. We can't blame COVID for this. Queensland didn't suffer the intensity and the severity of the COVID pandemic over the last 2 years compared to New South Wales and Victoria. And these issues and poor performance predate COVID. So whilst Queensland has only 65% or 2 in 3 of our ambulance patients being transferred in 30 minutes, New South Wales has 85%, nearly 8.5 or 9 in 10, and Victoria 72%. In fact, even more worrying is that the performance has been dropping over time. So Queensland deteriorated nearly 8.5% since 2019, 2020, and 15% deterioration from 2016. So given the lack of any real investment and structural change in the system, I can only imagine what the next report's going to show. And I suspect, and I'm happy to be proven wrong, but it'll be a slide worse, and it'll be a slide to worse performance. So we convened our ramping roundtable in Queensland to really look at real solutions to the emergency department pressures and what we as a system and we as an AMA could recommend to the government to do. We gave government a 5-point action plan. We asked for 1,500 new acute hospital beds. Now, these are going to be beds in ED and the wards to keep patients moving from emergency into the hospital. It's really about that process of getting patients out of emergency department so you can reduce the ramping from the ambulances into ED. And of course, we need staffing to go with those beds. There's no point funding new beds if there's no staff to go with them. And that's doctors and nurses that we're going to need, and all the other support staff and the allied health. We need a fully operational acute hospital that functions 7 days a week with extended hours, so that if someone's ready to go home on a Friday but can't get access to a physiotherapy or an occupational therapist, that doesn't keep them in hospital to the Monday. That needs to be done on the weekend. We need to make sure people are moving through our hospital system. And in the same vein, we need to run our hospitals at 90% occupancy or less, because we need that extra capacity to allow for surge. We're running into the winter months, and we're already seeing the huge numbers of flu cases in the community, on top of the nearly 8,000 cases that we heard yesterday of COVID, and that's happening daily as well. So whilst we have these pressures, and whilst we're still in this time where we have significant need for hospital beds, we don't have any capacity. So if we do allow a redundant capacity, we allow for surge for these sorts of incidents. We need a detailed analysis and reporting of patient flow within hospitals. We need transparency here, and we need these metrics published, and we need to make sure that government's held accountable to them. We need alternative models of access to hospital care other than through EDs that supports the primacy of primary care. We made these recommendations before borders reopened and public health restrictions were eased. We've seen the pressures of the Omicron wave that's put on our emergency departments and ambulance services. In fact, one point in the last 6 weeks or so, we had almost 600 COVID patients in our hospital, 3,600 healthcare workers and paramedics furloughed due to being infected or being a close contact, and the fourth highest number of OOO calls in one day in history. So dire was this situation that callers to OOO were also hearing pre-recorded messages. Satellite hospitals, which the state government's talked about, are not the solution to the ED pressures. They're mostly going to be dealing with outpatients and with non-acute therapeutic needs, not people who would be admitted to hospital and need acute care. We need to fix the problems and a real increase in funding so we can have more hospital beds in the start. If the federal government lifts the share of public hospital funding to 50% from 45%, that's an extra $1.5 billion a year for Queensland's public health system. That would easily pay for the 1,500 new beds and the staff to resource them. We need a federal government that will commit to lifting its share of public hospital funding and to also scrap the 6.5% funding cap. And that will mean that the Commonwealth will only fund an extra 6.5%. And given where inflation is at the moment at 5.1%, that really leaves nothing extra for services. And we know that, that those funding caps are met most years. So it's a very dire picture to paint of the system in Queensland, but if we don't do something now, the only other option is to do nothing. And to do nothing is quite disastrous. So I will end there, but I'm happy to see if there's any discussion that flows on from this.
Bav, thank you. And yeah, dire is the word I would use to describe what you just laid out there. Rob has made a comment in the chat group saying some of the ED consultants I work with have likened our current state to operating continually in disaster medicine, where we do the best we can for those we can and recognise that we're going to have poor outcomes for some others. Disaster medicine shouldn't be a continual state of being for a first world health system. Rob, thank you. Keep your comments coming through this evening. I want this to be a dynamic and vibrant conversation. Our next speaker tonight is Dr. Kim Hansen, who was chair of the AMA Queensland Ramping Roundtable and is an emergency physician. Kim, can you tell us what it's like on the ground?
Yeah, thanks, Rebecca. My colleagues and I are quite despondent about the situation at the moment. In every emergency department in the public hospitals around the state, there's patients waiting in the waiting room for hours and hours and hours. And these aren't patients who shouldn't be there. These are ones with real pathology who need our help. We see patients sitting in chairs in corridors because there's not enough beds in the emergency department because they're filled with inpatients waiting to go to the wards. We see the ambulances ramping. The KPI is 30 minutes, but sometimes it can be hours with them sitting there. And of course, no real treatment can start in a waiting room chair. It can't start in a corridor chair, and it can't start on an ambulance trolley. This causes us pain to see our patients distressed like this. We know we can help them, but we need a treatment space to do that. And we need some time to do that. And that's what we don't have right now. AMAQ has supported us so well through the Ramping Roundtable. And if you haven't had a chance to read it, please get your hands on it. I know the link's in the chat and have a look. My colleagues have been through a lot over the last 2 years. We've felt like we put our lives on the line at one stage there just to go to work. We had colleagues in Victoria end up in intensive care, and sadly one emergency nurse died in a Victorian from an infection in a Victorian emergency department. Now we're vaccinated, we've got PPE, we feel better and we do turn up to work, but the stress levels are huge. The burnout is huge. And we're calling on the federal government to act. We know that the funding isn't right, that it needs to be 50-50. We know that acute hospital beds are filled with NDIS patients, more than 500 in Queensland right now. That's like building a brand new, huge, big central hospital here, and that would change things. We desperately need investment, but we also need to be smarter about how we use our beds. In emergency now, we can change over that patient's bed in 30 seconds, quick clean and out. Every minute is accounted for, and it needs to be like that everywhere in the healthcare system. We need the leaders to adjust and innovate and lead these changes so that everywhere is accountable, that patients don't necessarily have to sit in a bed all weekend just to get a physio review on a Monday or to get an MRI on a Monday. We need better ways of doing things. Every day, I think my colleagues and I feel that it's getting worse, and this year has been the worst that it's ever been. We just haven't seen the numbers of people presenting. It's a combination of pandemic, it's mental health stress that's built up, it's aging population, it's medically complex patients, and it's even just simple things like population increase as people have come to the sunnier state. But we're hanging in there, and we're just hoping that with the focus on health that we're seeing, that we might bring about some change, because we can't keep doing what we've been doing. Thanks, Rebecca.
Kim, thank you. And again, I think there's a really strong theme developing in terms of the assessment of where public health hospitals are at tonight, which is the focus of the first portion of our conversation. We'll get to Medicare and GPs in the second part of tonight. Erica, thanks for your comment saying satellite hospitals are not hospitals. As Bav said, they are mainly focused on outpatient services. This is a blatant misconception that's being promoted to the general public. We're going to hear now from a patient, Melissa, who's a mum of 3, who's going to share her experiences of poor health and also visiting an emergency department. Melissa? Floor is yours.
Thank you. Look, as you said, I'm 40. I'm a mum of 3. In October, I was diagnosed with gallstones. So I ended up in an emergency. I went in an ambulance. That day, I had to get someone to look after my kids. My husband came with me. They told me straight away that day that they didn't have any beds available. So I would have to go home at some stage. They would try to get my pain at ease, and they also told me they couldn't even do any ultrasounds or anything that day also because they were that busy. So I stayed in ED for probably 5 hours, and I could hear everything going on. There was a lot of patients with mental problems. There was alcoholics. There was a lot of elderly. I was listening to it the whole time because I was sitting there. I then came home. I had another gallbladder attack, but having 3 kids, I just can't go back again. So I just put up with it. I then went to the doctor, got referred to see a specialist. Unfortunately, as a mum of 3 kids and only 1 wage coming in, we can't afford private health at the moment. So I went to through the public system to see if I can get a specialist to get my gallbladder removed. I then received a letter about 2 weeks later saying they'd received my referral and someone would be in contact with me within 365 days. So the pain is horrendous. I've had 3 kids naturally, and the pain is like labor. It is horrendous. I know it's not life-threatening, and that's what they tell me when I go up there. It's not life-threatening. You can get through it. However, being a mum of 3 kids, I can't go through that pain in front of them. It's horrible. The second time round was the 1st of March, actually, this year. I ended up waking up at midnight with a gallbladder attack. My husband instantly said, "I'm not calling the ambulance. You're not going up there." I was like, I put up with it for an hour and a half at home, and I'm like, no, I have to go. So we called the ambulance. As everyone knows, with gallbladder attacks, it can last for half an hour to an hour. It just depends. I was in excruciating pain. I got to the hospital. The pain was easing. I still was in pain. The hospital said there was no beds. So I literally went straight from an ambulance bed straight into the waiting room in the freezing cold for about 2 to 3 hours. This is at 3 o'clock in the morning. By 6 o'clock, I finally got in to see someone and they said, how's the pain? I said, well, it's pretty much eased now to what it was. They didn't give me anything. They just let me sit in the waiting room. I then said, is there anything I can take? They said they had no beds, so, I could go home. I said, is there anything I can take stronger? The nurse at the time said, if you want Penadine 4, it's a 2-hour wait for a doctor for that. So we suggest you call your doctor and get a prescription that way. So, which is what I actually did. At that stage, my doctor, Dr. Maria, actually was just mortified in hearing that I had to wait 365 days to even see a specialist to get my gallbladder out. So she made it more of a priority. So I have actually seen a specialist now. I got to see them and they're kind of still putting me off to a certain degree. But I guess it's classed as elective surgery, and I have to put up with the pain like pretty much monthly. And I know now it's just too hard to go to the hospital to just be sent home. It's just too hard, so I just suffer. Even this week alone, I haven't been to my doctor even, but I've been in pain and I just was like, I just got to put up with it. If I had private health, I think it costs about, like, to do it normally, it would be about 13,000 out of pocket, which I just don't have at the moment. And I guess from a patient's point of view, it's not like I want Botox. I need something to stop the pain that just keeps going on.
Doesn't seem like an unreasonable request. Melissa, I'm really sorry that that's been your experience, but really valuable to hear from you tonight. Thank you.
No worries.
So let's just have a quick chat just to wrap up the first section on the state of public hospitals in Queensland with Bav, Kim and Omar. And feel free to ask some questions in the chat as well. Omar, how does Queensland compare to other states? Could this conversation be replicated around the country?
Unfortunately, we're having exactly the same conversation in every state and territory, but there is no doubt there is some variability, as Bav pointed out. Queensland hospitals do better on some measures than other states. New South Wales also relatively good, and at the bottom of the pile traditionally tend to be Tasmania, ACT and South Australia. But there are different pressures on different systems. So, for instance, in Western Australia, where I'm sitting tonight, there's extraordinary levels of ambulance ramping, more than we're seeing in some other states for, with a population of 2.5 million people. So we're seeing different symptoms of the same problem, which is extraordinary overcrowding. It was already there pre-pandemic, but with the extra demand of the few hundred people in hospital with COVID, the thousands of health staff taken out of the system due to COVID or furloughing, and on top of the background growth in demand, the aging population, the fact that Australians are living with more and more chronic diseases, obesity epidemic, etc. You add all these factors together, and that's why every single state and territory is struggling. Every single state and territory is going backwards, especially on ambulance ramping, but also other measures of hospital performance. And that's why we really need to act now to try and change this trajectory. Otherwise, it's just going to be catastrophic within a few years.
Kim, how long have you seen ramping and access block to hospital beds, and what's caused it?
Sadly, it's been around for some years now. I guess access block really started in the 2000s. There was a push through the 90s to decrease the size of hospitals. So we were just left with an inadequate number of inpatient beds, and we simply haven't caught up in terms of inpatient beds. Queensland has the lowest number of mental health beds per capita. And even for other general beds, we're not where we should be for our ageing population. Ramping, on the other hand, is probably a newer phenomenon, but still a good decade since, I guess, bypass was changed into load sharing. So hospitals used to go on bypass, but of course that just meant the hospital down the road then got overwhelmed. But what we're seeing now in terms of the hours that the ambulances have to wait, the lost time, is the worst it's ever been. We simply cannot keep up with the volume of people coming. People are having longer and longer waits in waiting rooms, and cases like Melissa's really show what the problem is. You know, gallstones or biliary colic, this is ED's bread and butter. You know, we know this stuff back to front. We're the place where patients should come with acute pain. We know what to do to manage it, and most of the time we can do that and get them back home again and get them into surgical outpatients. But we simply can't do that now. We can't, we can't manage these patients, and that causes us, pain to see that, to see all these faces in the waiting room, to know what they're in with, and know that we can't help them. So I think, we're really hitting crisis mode now. There's cases of harm again and again and again from patients who were in the waiting room too long or had their entire episode of care managed in a chair in a corridor, and you simply cannot get good care in that way, and then bad things happen to patients.
Kim, just touching on the mental health aspect that you mentioned there, Vikas, thanks for your comment in the chat group. Vikas says, in psychiatry, I work in an inpatient unit where I see a number of psychiatry patients on an NDIS package. It's underfunded. Somehow their funding expires or the provider can't give care. They end up in an acute inpatient unit, occupying a bed for a few weeks or months until the accommodation and support is sorted. This blocks the patient flow and impedes care for patients who require acute beds. Bav, this has been really focused on patients and the public, but what's this pressure doing to the healthcare workforce?
Yeah, I think that's an excellent question, because despite all of these negative connotations and feelings we have towards the system and the bed block, it's happening despite healthcare workers doing their best. So they're trying their best to look after their patients, and there's a huge psychological trauma and a moral insult, I think, to people who are working in an environment doing their best, but the system's not there to support them. If you are in an ED and you're seeing the array of ambulances outside waiting to offload patients whilst you are inside the ED looking after patients, knowing that you can't get them into the hospital's beds that they need, that's not going to sit well with you, and it's going to make you, it's going to burn you out. And that's what we've been hearing, and we saw that on the word cloud before, the word burnout coming up. So we've gone through COVID. Our frontline healthcare workers have really done it tough, and then to come out of that into a system that still hasn't had any reform or change, it really is depressing. And I think the sentiments of those we've seen today. But if we don't do anything about this, we're really going to impact our future workforce. We're going to be making our younger doctors and our younger health graduates coming through pick careers or pick options in their careers that isn't in the public interest. So there might be people who go off and work in the private world. There might be people who choose specialties that aren't going to be facing the same burden, and we don't want that. And so there's really a lot of work that we need to do. We need reform. We've got two options, really. We do something or we don't. And if we don't do something here, I think the consequences are not what we or the public would like.
Bav, thank you. I just want to throw into the mix a comment from Dilip Depilia, who says, our doctors, nurses and staff and EDs are the forgotten heroes of our public health system. Through the pandemic and also in the current COVID normal environment, where would our communities be without this sort of dedication? Hats off to all of you. Thank you. Okay, we're about halfway through tonight, folks. We've had a look at the public hospitals. I'm sure many of you note that, it's barely scratching the surface, but let's get on to the second part of this evening, which is the Medicare session. And there's a lot to talk about with public hospitals, but of course they're part of a bigger health ecosystem, and the key elements of that ecosystem are Medicare and of course general practice. Before you hear from our speakers on this topic tonight, let's see how you would describe Medicare in 3 words. If you had to choose 3 words to describe Medicare in Australia right now, what would it be? You know the drill from the first word cloud that we had. So dive into the chat section and enter your words. Which 3 words would you use to describe our Medicare system? And keeping in mind that a little later tonight, you're going to be hearing from a number of politicians who would seek to represent and hopefully bolster the care in the industry that you work in. So go for it with the words to describe Medicare. Insultingly underfunded, the first 2 terms that have come through. Overly complicated, broken, too complex, and archaic has come through as well. Cheap and miserable, says someone. Interesting to see the word wasteful in the mix there as well. Outdated, says someone else. And someone says not representative. A GP nightmare, and you're about to hear from a number of GPs this evening who will respond to that as well. Lacking, inefficient, and grossly underfunded. Frozen, which is an interesting way of describing a long championed system, but maybe it's time to thaw. Complex, lacking, inequitable, so someone else. To be reviewed is the call from someone online too. Thank you. Keep your thoughts coming through to describe Medicare in 3 words. So let's hear from Dr. Maria Boulton, who is the chair of AMA Queensland's Committee of General Practice and a GP owner herself. Maria, good evening.
Thank you, Rebecca, and thank you, Melissa. You are so brave and an extraordinary person. Thank you so much. So Medicare was set up in 1984 with the promise of providing universal health care and to help pay for our out-of-hospital services. Some politicians perpetuate the myth that the current Medicare system is still doing what it was designed to do, and that Medicare rebates are still sufficient to continue funding quality free health care. This graph, let's have a look at the graph. Thank you. This graph shows how the indexation of Medicare rebates have lagged significantly behind the actual cost of providing healthcare. This was exacerbated by the indexation freeze occurring between 2014 and 2017, and the lack of correction once the freeze was lifted. It is this gap in funding that is a burden on vulnerable patients and vulnerable parts of the population. I'll just wait for the screen to stop sharing. Thank you. Pressure is also felt by GPs and non-GP specialists as they try to continue providing quality healthcare in the face of woefully low Medicare rebates. More recently, this has been exacerbated by the stark increases in cost due to the COVID pandemic and inflation pressures such as inflation in wages, consumables, and rent. Just 7.4% of total government health expenditure is directed towards general practice, and it's declining. The end result, and why we are here discussing this today, is that this is affecting the community, as Medicare rebates are your rebates, your public health insurance. If general practice continues to be neglected by government after government, the community will not be able to access the quality health care services they need and deserve. GP practices will continue to close, as we have seen in places like Boulton and Blackwater, and patients will not be able to access the services that they can now. This will result in our already overburdened hospital system becoming more burdened. GPs do their best to keep their doors open, but this is not sustainable. According to the 2021's RSCGP's Health of the Nation report, 50% of GP owners are concerned about the long-term viability of their practices. Today, we are calling for leadership to help GPs keep their doors open so that patients don't suffer. The system we currently have does not reflect the ideals behind what it was designed for. This needs to change, and it needed to change yesterday. We need real solutions and not ineffective band-aids that seek to replace medically trained doctors with those who have no medical training, no medical degree, no specialty training, no training in how to diagnose, examine, prevent, or treat disease. Band-aid solutions put the safety of patients at risk. It takes on average 12 years of training to become a qualified GPs. GP are the bedrock of community healthcare. We care for you when you're sick. We prevent disease. We keep you out of hospital. We catch cancer early. We care for all ages, and in many cases, multiple generations of the same family. We are the ones you come to with your mental health issues, which have been on the rise due to the stress caused by the pandemic. We are the ones who care for your loved ones in aged care facilities and continue caring for you as you're waiting for elective surgery. Our community needs and deserves GPs who are appropriately resourced and funded. And it is our community that needs your help to ensure this happens. Thank you.
Thanks, Maria. And keep your thoughts coming through on GPs in the chat section as well. Kimberly's noted that there's extreme pressure on doctors as a result of outdated Medicare. Let's hear from Dr. Nick Yim, AMA Queensland Board Director and a GP in Hervey Bay for a regional perspective. Hi, Nick.
Good evening, Rebecca, and good evening, everyone. And thank you, Maria, for a very great summary. So as Rebecca's mentioned, I'm a GP in Hervey Bay, also a practice owner in Hervey Bay. For those of you who aren't aware, Hervey Bay is approximately 3.5–4 hours north of Brisbane. And we do have some of the highest levels of obesity, lung disease, heart disease, diabetes, cancer, and mental health issues. Unfortunately, this is further complicated by high levels of unemployment in a region that is approximately 10 years older than the rest of Queensland. So as you can see, in my region, it's a complex, multifaceted problem that needs additional funding, leadership, and collaboration across all levels of government to improve our health. So I might describe the situation on 3 levels: from a patient community perspective, the GP perspective, and maybe from a practice owner's perspective, acknowledging that Maria's already touched base on some of these things. So from a patient community perspective, I'm well aware of the rising cost of living. So this includes housing. So in Hervey Bay, Maribor regions, our current rental market is probably below 1%. The food costs are rising. The petrol costs are rising. We've noticed that some of the petrol is above $2 a litre, okay? And also, unfortunately, health just isn't on the budget. Most of my patients, they just want to put food on the table. They want to pay their rent. They want to care for their own loved ones, their children, their family. So therefore, when the unexpected health cost comes up, they'll struggle to put it on the table. So I've seen parents who put their children's health first prior to theirs. Some of my patients will often have to delay their medical appointment because they can't afford the gap out-of-pocket expenses. So as a GP, I would love to bulk bill every single patient that walks through my door. However, I'm also well aware by doing this is probably not going to be a sustainable model moving forward. As Maria has touched on, as a practice owner, we are small businesses, just like your small local mechanic, your shop owner, your local corner store. We are seeing a continued rising cost of running costs, wages, insurance, and our consumables, our dressings, our needles, our syringes, our face masks, our personal protective equipment. All those costs are also rising. Some of the other challenges that we face is attracting and retaining of doctors in a regional area. This also extends to regional area. And as Arlene's mentioned in some of the comments, it can be sometimes quite demoralizing when we see that sometimes we do get a GP in town, but they might leave to the bigger city 2 years down the track. So some practices, they might incentivize doctors to stay a little bit longer, maybe a minimum pay guarantee or other incentives. But we are seeing challenges because, let's face it, sometimes maybe their loved one, their partner, they can't get employment, also schools. And this is further potentiated in rural Queensland. So one of the big challenges is obviously for the patient is the rising gap. Obviously the Medicare rebate hasn't kept up. So that means the out-of-pocket expenses increase. I've noticed in Maryborough alone, there has been GP practice that closed down. They can't even sell their practice because of the doctors retiring. So that means some of their doctors, they leave 3 doctors short in that town. So we need an option. We want accessible GPs for our community. Obviously, we need training of GPs. But as GPs, we're also tired of band-aid solutions. We're particularly tired of dangerous pilots and experiments. We want a long-term solution. We just don't want a band-aid solution. So what we really need is federal funding, leadership, coordination that pulls together all the resources that we have, harness the goodwill, and hopefully we can support all the communities in Queensland. And we need a long-term plan, not a short-term election promise. Thanks, Rebecca.
Thank you, Nick. It's a heavy load that you're carrying tonight, and all the more reason to be grateful for you and your colleagues being here. I'm going to go to the political representatives shortly, who I hope are listening closely. They're going to talk a little bit about what they're going to do about some of the challenges that you're laying bare tonight. But I just want to, let me ask a short, sharp question first of all. Do we need more trained GPs? Will that go some way to addressing this issue, Maria?
We need GPs to work. I guess the issue at the moment is maldistribution of GPs. So we need for GPs to be able to work all over Queensland. We need to have incentives so that they can do that, and we need to support them well so that they can do that. In the future, it may well be that if general practices start closing, general practice may become, and it is already becoming, a career that may not be of choice to junior doctors. And that is not what we want to see, because then we'll have a real crisis in our hands. And let's not forget that those rural and regional communities, they need GPs. They don't need a non-GP. They need a GP who can respond if there's an MVA, if somebody needs a chest drain, if there's a baby that needs to be urgently delivered. So yeah, we need to think of all Queensland as well. Thank you.
And can you just explain in a bit more detail, Maria, what a coordinated approach would look like, what each level of government should be bringing to the table?
Medicare is federally funded, but we also work closely with our state. And for example, with the COVID pandemic, for example, GPs, along with our emergency and hospital colleagues, were at the front line. And GPs were screaming out for PPE to keep GPs, staff, and our patients safe. And it didn't matter where the PPE came from, whether it came from the state or the federal. We don't care. It's all the same taxpayers' money in the end. But it was extremely difficult to source, and even to this day, it's extremely difficult to source. And what we need is for both levels of government to sit down with GPs on the front line to talk about what we need. Talk to those GPs working in rural and remote areas. Talk to those GPs that are involved in GP training. Talk to those GPs that are involved in ACHOs. Talk to those GPs who are involved in aged care facilities, and come up with a concrete plan to move forward.
And Nick, if we can't get GPs to rural and regional Queensland, what about other specialties like psychiatrists, dermatologists? Is regional Queensland missing out on those doctors too?
Absolutely. So to give you an idea, in Hervey Bay, and we're not that far away, we don't have a hematologist, we don't have an ear, nose, throat surgeon, we don't have a public respiratory physician, considering that lung disease is one of the highest issues in Hervey Bay alone. So a lot of my patients do need to travel to Brisbane. A lot of my patients are over the age of 70, and obviously a big travel down to Brisbane can be a big burden on financial perspective, and also it's dragging them away from their hometown, which takes long for the recovery.
Thank you both. I think one other point that I just throw in, I know in my day job as a radio talkback host, I don't think the general public understands GPs as business owners. I don't think they really make that connection. And so there is still a prevailing attitude that, oh, you're a doctor, you earn a lot of money, why are you crying out for resourcing? And to that point, Chris Perry has put in the chat, $37 for a professional service does not cover the cost of staff, rent, consumables. No wonder GPs have to leave the poorer rural communities that can't afford the out-of-pockets that are needed to keep the general practice afloat. The GPs leave and no doctors to replace them, which goes to your observation too, Nick. So what to do about this? You heard the doctor's perspective tonight. We're in the middle, the final run of the election campaign. What can politicians do? Each of the political representatives here tonight has 2 or 3 minutes to outline their election commitment to you and to respond to what they've heard. And going in, I'll just make this comment clear as well, which I think is particularly prescient from Rob, who says health systems, including Medicare, need long-term planning. Planning by election cycle harms patients. It's that simple. We need politicians that can think beyond their own self-interest and re-election to have honest conversations with the public about the funding of healthcare and how we're going to pay for it. On that note, let me introduce Dr. Angela Egan, who is an independent candidate for Herbert. Angela, good evening.
Good evening, everyone. Thank you for inviting me. I am Dr. Angela Egan and I am the independent candidate up here in North Queensland, which is in Townsville. I speak to you tonight from Wulgurukaba and Bindal country, and full disclosure, as you said, I am a member of AMA and I've been working in this community for 12 years. I work as a surgical assistant currently in cardiothoracic surgery, but my passion is Indigenous health. And the reason I'm standing is for that very reason. Healthcare, you know, when you think about it, and I support AMA wanting to increase the federal funding from 45 to 50%, but honestly, there needs to be transparency about where this money goes. There is so much inefficiency in healthcare. Nobody seems to know where the money is or what's in the pot. We think about it, it's 80 billion federal dollars that goes into this healthcare budget, but less than 2% is actually spent on preventative medicine. So simply, it's just putting a Band-Aid on a broken leg. When we think about the greatest burden to our healthcare system being chronic disease, if we don't include the current pandemic, as already said, we're facing the obesity epidemic, and largely it's due to our lifestyles. It's what we put in our mouth. It's a lack of exercise, but we don't focus on that. Where I work, you know, we're doing the cardiac surgery, so it's after the fact, putting Band-Aids on it. The other thing is we're not addressing the social determinants of health, and we've already said that. We live in a poor community. There's no focus on education, federal funding cuts to education, housing, we're in a housing crisis. There's no safe living environment when you think about the Indigenous people in my community, and they actually don't even have access to quality food. So health is really low down on their list. And you need to be working, because that's the other social determinant. And when you think about the unemployment rate, we're not really addressing that as much as the federal government would like to say that the unemployment rate is quite low. That's not the true figure at all when you consider that well, I don't know about you, but I can't live on 1 hour of work alone. So how do we do this? We need to address those issues to start with before we can even think about healthcare. Think about if we address this and put the money into preventative medicine, a heart operation costs around $30,000 to the taxpayer. Here in Townsville, we are the tertiary referral centre for all of North Queensland. We do about, in the public system alone, 50 coronary artery bypass graft surgery. So that's around $7.5 million that we spend in our area alone. The other thing I haven't addressed, and I don't have the time, but and is my passion, is we look at rheumatic heart disease, and that's what we see a lot of. That's completely preventable and shouldn't happen in a wealthy country like Australia, but it happens. We do around 30 heart operations, valve operations, because of rheumatic heart disease. So there's $1 million for a preventable disease, yet there's no focus on prevention. So we've talked about elective surgery, and I'd like to talk about that as well briefly.
Yeah,
maybe we need to look at the fact that it's not. Yeah,
sorry, Angela, just so that we can get to the others.
It's actually urgent surgery. Yeah, it's elective surgery. Not elective surgery, it's urgent surgery. Why are we calling it elective surgery? There's a man, an 88-year-old gentleman who has volunteered in my campaign. He's now been put off for the 6th time for his cataract surgery. He lives independently, served our country in the Australian Army, but he can't get his cataract surgery. That means he can't drive to get his food because he can't see. If that man has a fall, breaks his hip, then what is the burden to the healthcare system then when he can no longer live at home alone? So the other thing, so I mentioned fixing the inefficiency. So allowing clinicians time to research about how we improve systems. And we can do that if we look at cardiac troponins and wait times in ED. When I was going through as an intern, it was 7 to 8 hour wait. Now we can get that down to 2 hours. And that's because we give clinicians time to try and research how to improve systems, but we can't because they're too busy treating patients and keeping their head above water. So they are the things that I'd like to work on, and I think that the true representation is what we need. And it is funding, but it's efficient funding or improving the systems. But we need more doctors. We need more doctors standing up, taking on a role at federal level, because then we can be part of the policy making. And we have lived experiences that no one has, so we understand that. So we advocate for healthcare and healthcare professionals. So I'll leave it at that.
Angela, thank you. I mean, your passion is clear, and you're also provoking a strong conversation in the chat section as well. All right, we've got a number of political representatives here tonight, which we really appreciate. Let's hear from Dr. Kamala Emanuel, who is the Socialist Alliance Senate candidate.
Thanks very much. So I'm speaking to you from Turrbal and Jagera country in Meanjin, Brisbane. And also for full disclosure, I work as an abortion provider for Murray Stopes. And at the beginning of the pandemic, I was doing fly-in, fly-out work to Rockhampton and Townsville. But unfortunately, those clinics plus the Gold Coast and Newcastle clinics have been closed. So my passion is for reproductive health care and abortion rights and justice for patients and the women and pregnant people. But I'm really glad that the previous speaker spoke about the social determinants of health, because I agree that they're the things that we need to do to reduce the number of people who have to have urgent care. And not only with housing and nutrition, but also reduction in pollution, a focus on workplace health and safety. So I think there's certainly a lot that could be done to promote community health before we get to needing doctors and nurses to treat people who've got diseases. Just thinking of health more broadly in that WHO kind of framework as being not just the absence of disease, but our general well-being. So I certainly am in favour of expanding the number of things that Medicare covers and expanding the funding for Medicare, improving the indexation so that it does keep pace with the cost of providing care. The Socialist Alliance, our approach is to support and extend Medicare, but ultimately to move towards a model of care that's basically like a fully funded model, not fee for service, but salaried position, so that doctors and everyone working in healthcare get the salary that we need, that we have a network of community healthcare centres, ultimately that are the local place that people can go to for their healthcare. But in the meantime, as we have that's a whole other discussion. So in the meantime, as we have that discussion, protect Medicare, expand it, and make it so that it's a functioning system, because ultimately healthcare is a right and should be available to people, to the public, paid for by the public, and be free of cost at the point of care. That dovetails in with our approach to expand hospital funding, and certainly at least 50-50 from the federal, and really wherever you'd have a Socialist alliance person in power, and clearly we know we're not about to get elected, but this is the vision that we want to put forward, and we do want people to vote for us. It's our vision is one where whether it's state or federal, we adequately fund the hospital and healthcare system, and that goes to expanding funding for aged care and NDIS as well, fully funding it, making sure that workers in the NDIS in aged care facilities are properly paid, so those services can be fully staffed, and in order to take off that that bed block issue that speakers have spoken about so eloquently tonight. And I think really with the combination of training enough doctors and all the other people that we need to make a health system work, and have people be fully paid while they're being trained, make it so that we've got dignity as healthcare workers, and on the other hand, making sure that things can be provided, high quality system can be provided so that the community has the healthcare it needs. And I'll just end on the other point that we're raising, and that is my passion, which is that we want to have adequate funding and the discussions with the states so that we can establish reproductive healthcare hubs, because we want for abortion and contraception care to be funded and paid for, because at the moment, women can get, in general, can go to hospital to have their baby if they need to, and may be able to access hospital care to have a miscarriage treatment if they need to. But abortion, which affects about 1 in every 5 pregnancies, is treated as this thing that's hived off to the side and stigmatised, and we want to have it treated as healthcare and be accessible for free in the public hospital system with dedicated staff, so that no one's, we don't want to be making people forced to provide care that they disagree with, but we want to recruit and train and retain staff to provide that with the dignity and respect that every patient deserves in every encounter.
Kamala, thank you. Yeah, an interesting concept around reproductive hubs. To that point, in fact, Angela and Kamala, I'll come back to you, both of you as doctors in the system. There's a suggestion here made by Lawrence, who says, let's not just think outside the box, we should explode the box, explore the concept of a federal public general hospital for seniors. We've had children's hospitals for 100 years. Seniors have mirror special needs, but in reverse. So I'll come back to Dr. Angela and Dr. Kamala for thoughts on that. But let's go to Senator Nita Green from the Australian Labor Party. What is the ALP promising or committing to in terms of health in this election, Senator?
Well, hi, Rebecca. Thank you for having me, and thanks to everyone who's joined us tonight. I'm obviously, some of you know me already. I really care about this issue, and that's why I'm here. I do want to acknowledge that I'm actually really shocked and upset that no one from the government has turned up tonight. I fully respect the other political candidates that have joined, but it is really hard to have a discussion about what our system of health will look like if we're not having a discussion between the two parties that will form governments, that's really disappointing. But I'm here, and I really want to talk to you about some of the things that I've been involved in. From a personal experience, my mum is a nurse, and I think maybe that's why I've always been really interested in this idea. I live in Cairns up here, so I'm a consumer of regional health. I've had the same experiences with a lack of GPs, and I've had to go to our emergency department in the middle of the night during the first stages of one of my pregnancies. So it's something I care about from my family's point of view as much as being a representative of the people here in Queensland. I will say Cairns is a very small world, and this is a very small community who we've got online tonight as well. I won't name names, but one of the doctors online actually was part of the delivery team of my baby that I gave birth to 10 weeks ago. And when I saw her face in the delivery room, I was really reassured, because GPs are trusted people in our community. And I think that's something that I wanted to acknowledge. From a hospital point of view, just quickly, because I know we don't have a lot of time, certainly, I think Labor has indicated already that we want to work more closely with the states on hospital funding and just delivery of health services through hospitals. We're not getting that under the current Morrison government. You would have seen, obviously, during COVID particularly, there was a real lack of wanting to work with the states when it came to hospitals and the way that hospitals were preparing to deal with COVID. And I just thought that was remarkable and really disappointing. It was this attitude that if the states didn't have the resources that they needed, then they needed to deal with that. And it wasn't up to the Morrison government to actually step in and work with the states to prepare our hospitals for what we knew would be the wave of COVID. So, we acknowledge we need to invest in workforce. And I'm also really proud of our aged care commitments, because I do think that there are a lot of people who are currently sitting in hospitals who are not getting the care that they need in aged care facilities. And like Melissa, who joined us earlier, when I was sitting in an ED department, I was sitting next to someone who had come from an aged care facility who probably could have been treated if there were nurses in aged care. So that's something that we have been talking about. I just want to touch, I know we don't have a lot of time, but I just want to touch really briefly, and I'm here to answer questions as well, on the GP shortage, because I'm not sure if everyone knows, but I moved a Senate inquiry in the Senate, a motion to get that up, and the government voted against that inquiry. We were successful because we were supported by the Greens and other crossbenchers, and we've been running that inquiry since last year. We've been having hearings all across the country, and we have delivered an interim report at the moment, and I encourage everyone to go and have a look at that interim report. We've reserved our final report until later in the year, and I hope no matter what happens at the election that we get a chance to continue that work, because we are hearing a lot of really important evidence about the impact of lack of GPs are having on people's health. And we've made some recommendations which deal with training of doctors, the maldistribution of doctors, and also making being a GP a career of choice. We've also recommended the government does have a look at the Medicare rebate, and we acknowledge the impact that the freeze that was put in place for 6 years by the LNP has had on GPs, and we that came up over and over again during that Senate inquiry process. I really want to, acknowledge that Labor has made a number of commitments in primary health during this campaign. I have a lot of respect for Omar, like a lot of respect, but I don't think it's fair to say that health hasn't factored as part of the major issues that is being talked about in this campaign, because every day in Cairns at least, we've been talking about healthcare, and we've been talking about the commitments to reduce the cost of medicines, to increase newborn screening, to make sure that we have urgent care clinics to deal with some of the crisis that we're seeing in parts of regional Queensland. And we're also talking about, we've matched what the government is putting into rural and regional health in terms of funding there. So there's certainly more work to do. And what I'm really hoping is that we get a government that cares about healthcare, wants to be part of the solution, wants to talk and work with our states, and doesn't think that this is someone else's job.
Senator, thank you. You are guaranteed a job in the next parliament, possibly in government, but you know that 23 out of the 30 seats in the lower house are currently held by the LNP. So whether or not your party's done a good enough job of convincing, in particular, perhaps regional Queenslanders, that you'll do better on health will be revealed if that's a priority. You mentioned the Greens there, so appropriate now to bring in Penny Allman-Payne, who's also Senate candidate for the Queensland Greens. Penny, what are the Greens prioritising in terms of health?
Thanks, Rebecca. And can I first of all say thank you to everyone for sharing your experiences tonight, both from the medical profession and patients. I think it's really important that we're listening to various groups when we're forming policy. I'm a secondary school teacher, and there's lots of parallels, I think, between the public hospital system and education that I'm hearing. Things like chronic underfunding, overwork, an obsession with data when governments don't like outcomes and manipulating the data rather than really dealing with the root cause, and issues around rural and regional as well. I've actually taught all over Queensland. I'm currently based in Gladstone. I've worked on Cape York, I've worked in Wide Bay, Burnett, and I've also worked in Southeast Queensland. Look, I'm going to focus really I'm going to focus in on those things that are relevant to the topics that have been discussed this evening, but I just want to preface it by saying that the Greens are actually taking 9 health-related policies to the federal election, and I'd really encourage people on the call to have a look on our website. There's a lot of detail there. They're costed by the Parliamentary Budget Office, and I think there are many things there that cover a lot of those intersecting issues that people have talked about this evening. But to drill down straight into those things that people have talked about tonight, so in relation to hospital funding and Medicare, I'm actually going to go to Medicare first. I'm going to make it short and sweet, and that's that we want to push to increase the Medicare rebate provided to GPs, and we want to set that rebate or that price in consultation with professionals. So I'm certainly hearing loud and clear this evening that there are real issues there. In relation to hospitals, the Greens want to do 3 things to clear waiting lists and reinvest billions into that system. We know it's chronically underfunded and has been for a long time. So the 3 things that we want to do, the first one is we want to stop the handouts to private health corporations by abolishing that private health insurance rebate. We think that that $59.4 billion should be reinvested in the public health system. We want to clear the public hospital surgery waiting list with a one-off investment of $875 million. That's a one-off payment to states and territories. We need to clear that backlog, particularly that's arisen after COVID, and that would apply to clinical urgency categories 1, 2 and 3. And finally, we want to invest an extra $8 billion by legislating an equal 50-50 funding growth of hospitals between the Commonwealth and the states to ensure faster access to more services. I think I just really want to underline too that there's been a lot of comments tonight about how do we fund things. The Greens are really pushing hard on the idea that we actually do have access to money in the economy if we're prepared to tax billionaires and big corporations and have them pay their fair share, things like stage 3 tax cuts. We've identified $547 billion that could be redirected to the services that we need in health, education and various other areas. So I'm going to leave it there, and if people have questions, I'm really happy to answer them later on in the session.
Penny, thank you for being here. We've only got about 15 minutes before we wrap things up, so a quick Q&A session with all of our political representatives, and then Professor Chris Perry is going to give some final comments to tonight. So let me just circle back to some of the issues that Dr. Khorshid and Dr. Manoharan raised tonight in terms of public hospitals, patients in beds who can't find aged care accommodation. Angela and Kamala, Lawrence raised the idea of a public general hospital for seniors. Is that something that you could see being a practical part of the solution here? And Angela, I'll start with you.
Yes, absolutely. When I talk to the ED consultants in our hospital, it's not actually the front door, it's the back door. So if you look at at least 10% of the beds are taken up by elderly patients waiting for a place in nursing home, then absolutely. And as someone else already pointed out, it's treating elderly patients is very different to treating children, to adolescents, and in fact the reverse. So why do we not see geriatrics as a specialty within itself? Because it is. So absolutely, I would support that. I would also support the fact that we've had a Royal Commission into aged care and none of those recommendations have been implemented. We look at the money, the actual money that aged care, private aged care generates in profits alone, but that's not put back in to quality care. So
okay,
that's my stance on that.
Kamala?
I'm liking the concurrence of views here. Yeah, I agree. I think that would be a very interesting thing to investigate and look at funding, and just for the same kinds of reasons that we've ever had, you know, specialist women's, children's, and other specialty hospitals. And I guess just to reiterate that having adequate funding for aged care facilities and expanding the number of quality places there, and having adequate funding for NDIS participants, I think in terms of reducing the bed block at a geriatric hospital as well, because there wouldn't be any point in just funneling seniors into a specific hospital, but still not having the capacity to then get them back out into residential facilities or home when they're ready to leave hospital and acute care settings. Yeah. Thanks for the question.
A quick comment from each of you two, Kamala and Angela. What are your patients telling you that they need from the health system? Are there any sort of themes coming through there, Kamala?
Women who are undergoing abortion, and they do need treatment with dignity. And so in particular, I mean, right at the moment, a lot of people are accessing abortion privately. There are some excellent GPs who are also providing medical termination with mifepristone and misoprostol. So knowing how to access those GPs and knowing who is and who is not a GP, who's an empathetic person, who is non-judgmental, knowing how to access those people is a challenge. Knowing for GPs to know how, like if you're a GP who is in a hospital catchment area where you could refer your patient to the hospital for the abortion that they need, and that will either be provided in the hospital, or the hospital has an arrangement with an organisation like Marie Stopes to refer for the care privately. Just for GPs to know where to do that referral, then to be treated with dignity. If you need to, even if the hospitals can't currently provide terminations of pregnancy, but if someone comes for treatment of a complication, to be treated with dignity and respect in the emergency room or on the ward, to not have the decision to undergo abortion questioned or shamed.
Yeah. Angela, in North Queensland, can you speak to some of the themes that come through in terms of what patients are saying they need?
Yeah, sure. I mentioned before, 88-year-old gentleman living alone, quite independently, just needs cataract surgery. So why aren't we utilising that? Well, why aren't they outsourced if the public system can't keep up? We've got plenty of private facilities where he could have his cataract surgery to live independently. There's a lady waiting for, and it's obviously a surgery focus, but lady waiting for a rotator cuff repair who can't move one of her arm, needs to drive a car, which she can't do. So they're the things I guess I hear about, of people waiting for surgery because it's classed as elective surgery and not considered urgent surgery, but the impact for that person is significant.
Senator Green, Lee's asked a question in the chat. Can you give your view on the Queensland Government and Pharmacy Guild's pilot in North Queensland? Senator, do you have a view on how that's playing out?
Well, as I said, I'm really keen to work with the Queensland Government if we're able to form government, but I'm not here to speak on their behalf. That is a policy of the Queensland Government that they've put in place. I am keen to see how the trial goes. I know there are very strong views from doctors, and I share concerns that people won't get the full extent of a healthcare experience if they're not going to be able to speak to a doctor at the same time as getting a script for a UTI field or antibiotics field. So I have heard those concerns. I wasn't part of that decision-making process because that's the Queensland Government. We'll see how the trial goes. From our point of view, from a Labor point of view, if we're able to form government, which I hope we do, because I think we'll be able to work with the Queensland Government on saying, would we even need to go to the point of having a trial like this if we were investing better in Medicare and having more access to GPs, because as a consumer, I can tell you it is really the prospect of going to a pharmacist to get a script filled when you cannot get a GP appointment. Like, I've spent hours and hours and hours on the phone calling around GP clinics, and it's not to blame those clinics. They're just so overworked and exhausted that they're not taking on new patients. They're not taking on people who don't have an appointment in advance. So it's a delicate balance for us, and we'll see how the trial goes. But I've heard the concerns of doctors who are probably online tonight, and we'll take those into consideration.
Okay.
Once the trial's completed.
Angela, you've got your hand up. Do you want to weigh in on this?
I most definitely do. The problem is this is why we need doctors at a federal level, because you don't understand, Nita, that this trial is completely dangerous. Nobody in my community knew about it till I started to talk about it. Why do you need to access a pharmacist for something like blood pressure medication? How's that urgent? For cholesterol medication, for diabetes? The problem is those 23 medical conditions that are listed are not a quick fix solution that just require medication. So I think if you just want to run with this trial, then why are you not talking to the doctors that were on the steering committee that have all pulled off the trial, telling everybody this is a dangerous situation? In fact, it's not going to make it better. It's going to make it worse. You will burden our healthcare system, the ED system.
Respectfully, it is a Queensland government trial and a decision from them, and I really look forward to working more closely with the Queensland government if we are able to form federal government, so that we can work with them to not get to a point where they feel they need to go down this route.
Okay, you can see that people are weighing in really passionately when you have a look at the chat on this particular issue. Senator, I want to go to another election promise that's been made by Anthony Albanese, and that is around urgent care centres. Steph's asking, given there's a GP shortage across Australia, who's going to staff them?
Well, they'll be staffed by GPs and nurses, and we will be working on more promises and working on making sure that we can train locally, train doctors locally to make sure that we can staff those urgent care clinics. It's not something that we're expecting to do on day one. It's not something that we think is an easy fix. We're not planning on having them staffed fully on day one, and we know that there's a workforce shortage that we need to work with to fill those urgent care clinics. But again, the community is telling us that they are not able to get in to see GPs. They're ending up going to our emergency departments. Our emergency departments are full. This is a trial. Again, it's a trial of 50 sites, and we'll make sure that the reporting and the data is transparent on how those sites go.
Okay. Very conscious of time, and we'll wrap up in just a moment. Just one quick response from you, Penny Allman-Payne. I mean, you're coming in potentially as a newbie to politics. You're hopeful of getting into the Senate. I mean, health should be an area that there should be a level of consensus and compromise on. You're campaigning around the place with long-term senators like Larissa Waters. Are you optimistic that doctors' voices will be heard by whoever or whatever shape the next parliament takes?
Look, I'm optimistic that if the Greens get into balance of power, including in the Senate, that we can deliver on health. We did that in 2010. We got dental into Medicare, and that's really improved the outcomes for a lot of young people. What I'm hearing loud and clear on tonight's call, and what I've experienced myself as a consumer of health services in a regional area, is that there is much that needs to be done to fix our hospital system in the same way that there is in a range of public services in this country at the moment that have been underfunded and hollowed out. So I'm really confident. We've worked with Labor before. We have been constructive in the Senate in putting up inquiries and dealing with legislation to make it better. I'm really confident that if we get into that situation in this government, that yes, we can work cooperatively going forward, because we have to. Our health depends on it.
Okay, great, thanks. And the Greens have made it clear, Adam Bant, your leader's made it clear that while he's not a fan of Scott Morrison or Anthony Albanese, that the Greens would back a Labor government if there's a hung parliament. All right, let's wrap up the finale, shall we say. Professor Chris Perry, do you want to give us your thoughts on what you've heard tonight and going forward?
Well, thanks very much, Rebecca. And I really want to thank the Secretariat of AMAQ and our technicians for putting this on. I was dubious, I must admit, about how it would go tonight, and it's just been fabulous. I think people who have been here have thought it's been very, very well done, very well put together. Look, Rebecca Levingston, you are fantastic. Thank you. The interviews we've had over the last 2 years, probably 4 of them, have been long and insightful, and they've changed government policy a number of times. So I congratulate you for that. It was great how you held it together tonight with a lot of difficult people. Doctors can be difficult to control. Look, it was a great night. Omar started out by talking about the underfunding of the public hospitals, the logjam, which in Queensland we talk about as ramping. Depressing words we used. Bav described ramping, how it's worse in Queensland than the other states. We need the federal funding to increase to be 50-50. We need the funding cap to be raised above the 6.5% per year. Kim Hansen, who's our champion about the ED departments being so overrun. Kim's not as despondent normally about the whole thing as she came across tonight, because she really is a great worker, and we hope things will change, but gee, we'll have to see. Mel describing her 12-month wait for gallbladder surgery, that's just ridiculous. And she was told it was not dangerous. Well, people die of ascending cholangitis. It's not a category 3 operation. Saving the general practice and the Medicare rebates. Maria runs a very, very large general practice in Brisbane. She brought up very clearly what the rebates are now sitting at about a third that they were. We know that the vulnerable in outer metropolitan rural areas are suffering. 7% of the total government health funding budget going to general practice. You'd think it'd be 50-50. Nick Yim talking about the extra difficulties of Maryborough and Hervey Bay and the doctor shortage. Look, our invited speakers, candidates in the next election, they were terrific. They seem to understand what's going on. Angela Egan, who's obviously an AMA member, talked a lot about social determinants. Of course, the social determinants aren't just in Aboriginal housing, they're in public housing, and that's a serious issue, and poverty. Kamala Emanuel with the Socialist Alliance, bringing up that MBS rebates should be indexed, and you'll have a very agreed audience here, Kamala. Nita, it is an election campaign, and did bring up the fact that the LNP aren't represented here, and that is a fairly shameful thing, really. She did, though, bring up all the Band-Aids, which ALP are promising. I know they're not promising the serious money that it requires, because they'll be, accused of blowing the budget. Hopefully that when they're in government, they may re-look at that. I've got a feeling they won't. And so I think the next election in 3 years' time will be all about health, and we'll be bringing it up every week over the next 3 years, because you guys so far haven't shown to be serious. And the LNP, if they are in opposition, won't let you forget that you didn't promise it before the election. Penny Allman-Payne, that's great. It's good to see the Greens are understanding things. My own perception of it, I'm not sure about getting rid of the rebates in private health insurance will make a huge difference. Maybe it will. It might also overwhelm the public hospitals. The specialty hospitals that Lawrence brought up about the seniors specialty hospital, sure, I'd like to see an Aboriginal or Indigenous specialty hospital. But the big thing about the seniors, the best figure is the one put out by Omar about 2 months ago. Since 1994, in the last 28 years, the number of beds in public hospitals in Australia, there used to be 30 beds per 1,000 people over the age of 65 in 1994, 30 beds, and now there are 15. That is why there's ambulance ramping. The North Queensland trial, Senator Green, that's terrific. hopefully your Senate committee will come out and say that's not a very good idea for primary healthcare because it's very dangerous. I hope you've caught that on tonight. You must realise also saying that will not be attacking the Labor government in Queensland because there's cross-chamber support because both sides of Parliament in Queensland seem to be needing or wanting the Pharmacy Guild money. So there's no problem with federal Labor, you, criticising state Labor about the North Queensland pharmacy trial because it just stinks and it's harming people. And to say you've got to wait for the trial when we've got 240 harms, of which about 35 are serious harms, is just ducking the evidence. But anyway, I'll leave that. Thank you, Nita. It's very kind of you to come along with us. And it's great to have you join with our 4 candidates. Good luck with this election for all of you. Many of you won't get in. Keep your heads high. And thank you for serving our country. Thank you. I've talked too much once again. Anyway,
we're pretty close.
Okay.
Thank you, Chris. And look, I hope that AMA Queensland can send a full copy of this to the LNP, who I'm sure, despite what obviously must have been a schedule clash, I would hope that there is an appetite to hear the very valuable insights that you've shared tonight. Lawrence, you say bring up the Seniors Hospital on my program. Happy to get in touch with me. I'm going to wrap with a comment from Sanjeev in the chat tonight, who says health is wealth and an investment in the future. It'd be interesting to see what the average life expectancy in this country is in a few years if we don't invest in health right now. Thank you so much for investing in this evening. Thanks to AMA Queensland for asking me to facilitate. It's been shocking, but it's been a pleasure to be here. Thanks so much and good night, everyone.